uh, of a
Good evening.
45.
One second, Dr. Deepak. Good evening to all, and welcome to the first of our case presentation series hosted by the IAPS NextGen team. So today we have our final year postgraduate, Dr. Deepak Goel from MAMC, New Delhi, and we have our two mentors here, Dr. Rajiv Redkar from Leelavati Hospital and Professor C. Shankarabharati, Professor in Institute of Child Health from Chennai. So over to you.
Yeah, can I just ask, how do we go about with this presentation? Do we interrupt you in between, or we finish the complete presentation and question you at the end of it?
Sir, so usually in the examination as well, what would happen is the candidate would be presenting the history. Then after that, he will be questioned about the history part of it. Then he would go on to examination. He'll be questioned regarding the examination findings and their implications. And then we can go on to the investigation and management, sir.
Fantastic. Thank you. You may begin.
Yes.
Yeah.
Thank you, sir. I am presenting a case of 45-day-old female baby girl from Aligarh brought by her mother, presented with complaints of yellow discoloration over eye and chest for 15 days, with clay-colored stool from last 12 to 15 days and dark-colored urine from last 12 days. Mother first noticed around 28 to 30 days of life some yellowish discoloration which was initially over eyes and face, now progressed to involve the chest, abdomen and bilateral upper thigh for last 15 days, which is gradually progressive and persistent with no days of clearing. Mothers also noticed clay-colored stool. Initially, the stool was normal in color and child also passed normal meconium at birth within 24 hours of life. After that, child passed clay-colored stool, which was first noticed around 28 to 30 days of life. Since then, clay coloring of the stool is persistent and no episode of normal stool color since then. Then, however, child is passing 5 to 6 times stools in a day in normal amount, soft, non-watery, and do not containing any blood or mucus. The stool are non-greasy, non-oily, and there is no foul smell, unusual non-foul smelling. However, the mother also noticed that from last 15 to 12 to 14 days, baby urine has also been dark yellow in color, and it also leaves a stains on the diaper. The baby passes at least 5 to 6 wet diapers a day. There is no foul smelling, no pain, no crying while passing urine. There has been no associated fever. There is no history of any fever episode, no history of any associated lump, distension, unconsolable cry, sudden irritability and flammableness. Negative history, there is no history of any previous hospitalization, any parental nutrition, any phototherapy, drug allergy. No history of any gum bleeding, hematuria, easy bruising, black stool and blood transfusion. Also, no history of any lethargy, persistent vomiting, altered sensorium and weight loss. Child is usually well, no history of constipation, the child having normal cry, no feeding problems, no history of cyanosis, seizure and collapse, no history of child is on exclusively breastfeed with no complaints, no history of any change in head size, no history of any constant watery nasal discharge, rash, lump, and decreasing lump activity. There is no history of any white spot in the eye noticed by the mother. Baby is playful and gaining weight. No history of any watery rash or seizure. Child is born at tough by normal vaginal delivery, first live birth, no consanguinity in marriage, cried immediately at birth, vaccinated at birth, meconium and urine passed within 24 hours. Birth weight was 2.6 kg. There was no jaundice on day 1 of the life, and there is no history of any NICU stay or exchange transfusion. Baby exclusively breastfed with good latch, and no prelactial feeds and immunized as per age. Mother has regular antenatal checkups. There was no fever with rash, no diabetes or thyroid disorder known to mother. She had not taken any TB medication or any substance use. Her blood group is that is B positive. There is no history of any maternal febrile illness during antenatal period. No history of any uncooked meat consumption. and no pets at home. No history of any painless genital rash or ulcer or any ultrasound abnormality during the ANC, which shows the baby has a restricted growth. There is no history of any abortions. No history of any conjunctivitis, severe bony pain and lumps in inguinal region. No history of persistent throat pain and no history of any leaking per vagina. The family history, there is no history of any neonatal jaundice needing admission, need of blood transfusion or heart disease in childhood, no history of any childhood surgery. Before coming here, the baby receives some medication from local clinic with no relief. Yes, sir. I have presented my history, sir.
Did you ask for antenatal imaging or a scan, doctor, for this baby?
Sir, the mother had no scans with her, but she had gone through the radiological scans at that time.
Okay, okay. Is there any clue in that antenatal scan?
Sir, antenatally there is no restriction of growth in the mother,
Okay,
in the baby,
okay, okay,
as per the history, sir.
okay, okay, okay. Okay, now you have finished the history. Now you're going for the clinical examination.
No, sir.
Yes,
Can
sir.
I ask? See,
Yeah,
Doc,
sir.
I think in your history, there was a significant negative history. So, can you summarize the positive points of your story in 2 or 3 lines?
Yes, sir. Sir, the baby is presented to us with complaints of yellow discoloration over eye and chest, which is persistent and progressive, and will start after 15 days of the life, which is associated with clay colored stool, which is also persistent, and there is no episode of clearing. There is also dark color urine, which stains the diaper. There is no history of any fever or there is no history of any fever or any distension to the child, sir. And also the rest of the antenatal family history are insignificant, non-significant, sir.
Okay. There is a question that can you justify whatever is negative that you have cited? For which reasons? What have you ruled out by the negatives that you have cited one by one?
Like in case of, sir, there is no history of any previous hospitalization means of any NICU stay for which babies, there is no history of any parental nutrition because pain is a cause of cholestasis. There is no history of any gum bleed, hematuria, easy bruising, black stool, which rule out the hemolytic cause of the jaundice, sir. No history of lethargy, persistent vomiting, altered sensorium, and weight loss, which shows that the baby liver is not in the failure state. The baby is well, no history of constipation, normal cry, no feeding problem. This rules out congenital hypothyroidism, sir. No history of cyanosis, seizure, and collapse. It rules out heart diseases, congenital heart diseases. No history, child is on exclusive diet with no complaints. It means it's rule out breast milk jaundice and breastfeeding jaundice, sir. No history of change in head size. It rules out. It's suggestive of there is no congenital toxoplasmosis. There is no history of constant watery discharge, rash, lump, and decreased limb activity. It rules out congenital syphilis, sir. No rules of white spot in eye. It rules out congenital rubella, sir. Child is playful and gaining weight. It rules out congenital CMV, sir. No history of any watery rash or seizure. It rules out possibility of herpes simplex, sir. The baby is normal. There is no consanguinity, sir. Yes, sir. These are my negative histories.
That's fine. So just go back to the slide of your positives.
Yes, sir.
No, the positives, the first one prior to this. Yeah. Now with this picture, okay, what would be your possibilities that go on in your head just from the history?
Sir, 45-year-old baby girl which had developed jaundice at around 30 days of life with it means the jaundice pathological, sir. It is unlikely to be a physiological jaundice.
Correct.
It is
So
also
what?
yes, sir.
Yeah, go on. Sorry.
No, sir. It is also associated with the clay color stool. That also suggested that it may be a cause of obstructive jaundice, and it dark color urine. It means the jaundice because of the conjugated bilirubin, sir.
Correct. So I agree with you that we are dealing with a conjugated, probably a obstructive jaundice. Correct. So this sequence of the timing, what differentials go through your mind on the basis of your history?
So on the basis of the history, the first of it is a pathological jaundice with a obstructive type of feature, and one of the most causes is biliary atresia in case of a young infant and choledochal cyst. These are the two important differential diagnoses. First, I would like to work upon them, sir. And I would also like to rule out other medical causes and surgical causes, sir.
Okay, fine. I would agree with you. And can you proceed on to your examination? Dr. Shankar Bharti, would you like to ask him anything on the history?
Yeah. Okay, let him proceed with the examination. No
Okay.
issue. Yeah.
Thank you, sir. I am proceeding to examination, sir. Sir, I examined child in warm, well-lit room, first on mother's lap and then supine on couch with adequate exposure. The child was calm, consolable cry, afebrile and well hydrated. Her vitals are normal. Heart rate is 120 beats per minute. Respiratory rate is around 30 beats per minute. Auxiliary temperature is 98.6 degree Fahrenheit. With SpO2 levels of 96 at room air. With capillary refilling times of around 2 seconds. With blood pressure in right forearm is 80 to 50 millimeter of mercury. Her anthropometry weight is around the 68th percentile as per age. This length is 70 percentile. Head circumference is around 80 percentile. And development milestones are normal as per age. Sir, the child is usually playful. On general examination, sir, there is scleral icterus with jaundice, skin till upper thighs, and palms and soles are looking normal. There is no facial dysmorphism, no excoriations, and no rash. There is no pallor, cyanosis, clubbing, pedal edema, significant lymphadenopathy, and rash and fatigue, and there is no patrexia. On systemic examination, bilateral air entry are equal and just are clear. Pulses are good volume. Both heart sounds are heard. There is no murmur. Bilateral limbs are normal in tone, and spine is also normal, sir. On inspection of diapers, sir, semi-form clay colored stool with thin yellow watery rim, consistency non-watery, and no blood and mucus visible, sir. Then, sir, I went for local examination of the abdomen. Abdomen is protuberant, symmetrical, centrally placed umbilicus. The skin is jaundiced. All quadrants are moving equally or breathing. No visible peristalsis, sir. No veins, gauze veins, scars, hernia, and localized distension and flank fullness with any pulsation. On palpation, I confirm all the inspectory findings. There is no local rise of temperature. Abdomen is non-tender, soft. There is no guarding or rigidity. However, on deep palpation, liver edge is palpable 5 cm below the right subcostal margin in mid-clavicular line. It is firm, smooth, and non-tender. No other lump palpable. However, bilateral renal angles and flanks are full. 3. No sign of any free fluid. Hernial orifices are intact. The child is having normal looking female genitalia. On percussion, liver dullness started from fifth costis up to 5 cm below right costal margin. On auscultation, bioval sounds heard normally, and there is a normal parectal examination. And the finger stays echolic, sir, with echolic stool, sir. I have done my, sir, examination.
Infants, you do a perirectal examination or a gentle rectal stimulation with dilator. Infants and newborn, you are not supposed to do a rectal examination. Okay, it will be very narrow, means small anal canal and rectum. Okay, just use a dilator for examination of the rectal purpose. So just you want to see what is the color of the stool, no?
Yes, sir.
To see whether it is yellowish or a clay colored. Okay.
Yes, sir. Yes, sir.
Otherwise, your examination part is relatively okay. The abdomen is soft, it's not tender. Am I
Yes, sir.
correct? Yeah.
Yes, sir.
Okay.
Yeah, Doc, see, is this the picture that you have shown of the child that you have presented?
Yeah, sir. But yes, sir. But there is
But
no
there
spleen, sir.
seems to be another lump in the
No,
abdomen on
yes,
the left side, which you
sir.
have
That
not
was just,
mentioned on your palpation.
sir. The marking was not. There was no
What?
lump, sir. It was just the markings we were taking. There
Yeah,
was
but
no
what is
abnormal.
marked on the left side clinically appears like the spleen to me.
Sir, there was no spleen. Sir, it was the marking which I did mark. Yes.
It was what,
There was,
sorry?
sir, there was no spleen, sir. The finger are easily
So what has
insinuating
been
between.
marked on the left side?
So we were marking and like we were suspecting if there is any spleen. I took the picture, sir. Yes.
Okay, okay.
Okay.
The
Sorry,
other
sir.
thing,
Sorry, sir.
you know,
Yes,
no
sir.
problem. I mean, I believe you. It's not
Yes,
just
sir.
that the markings were not commensurate with what you've been talking. The second thing is the belly button. Okay, the umbilicus. See, I find it a little protuberant. Okay, and it's a common situation in children having such presentations to have a belly button that is protuberant, and sometimes there is a umbilical hernia. So have you palpated the umbilicus specifically
Yes, sir.
and checked that it is not having a hernia? Because it
Yes, sir.
looks
There was
protuberant and it looks kind of dipping down towards the lower half of the abdomen.
sir, there was no palpable defect on the, sir, there was no umbilical hernia. It was just
Fair
a,
enough, fair enough.
yes, sir.
But quite a lot of these children have such a problem. I don't know if you've experienced that or not. Okay, they have an umbilical protuberance or a hernia. Good.
Yes, sir.
Okay, the other thing is the liver edge. You have mentioned it is firm, it is smooth. Now,
Sir, yes, sir.
so in which direction is it smooth?
Sir, liver surface is smooth, sir.
Surface is smooth. So the liver
Consistency is firm,
surface is
sir.
smooth. And what is firm then?
Consistency of the liver, sir.
Okay. And the surface is smooth of what you are
Yes, sir.
palpating. Fine,
Yes,
fair
sir.
enough. Okay. Sir, Dr. Shankar Bharti, anything more that you want to ask on the...
Yes. Most of the patients with biliary atresia, if they present late, you are supposed to examine very carefully to look for the spleen. There will be associated splenomegaly also. Sir, as he mentioned that you have drawn that the area markers, but you are not able to feel the spleen. That is okay. But spleen also can be palpable in delayed presentation if it is a 2
Yes,
months,
sir.
3 months old baby, and there will be a gross abdominal distension and there will be a free fluid. Okay.
Yes, sir.
Okay. Yeah. Proceed with your next.
Sir, on basis of my history and examination, I have a working diagnosis of a stable child with 45-day infant with history suggestive obstructive jaundice with icterus and hepatomegaly. Other systemic examination are unremarkable with no syndromic and torstigmata and no right upper quadrant mass or ascites, finding suggestive of infantile cholestatic jaundice without any acute failure. Now I go for investigation part, sir.
Yes, go ahead.
Yes, sir.
Yeah.
On blood
So
investigation,
first
sir.
of all, sorry, before you proceed to your investigations, how do you plan to manage this child?
So first of all, if the child is unstable, I would like to stabilize the child because
No, but this child
sometimes.
looks very stable.
Yes, sir. Yes, sir.
So how would you plan to manage this child? before investigation, see, he's come to the OPD, you've seen him, how do you plan to manage them?
Sir,
What will you advise to the
Sir,
mother?
I'll explain the parents about what can be the what can be the what can be the diagnosis, what can be the further plans. If it is, if the child may require surgery, or it can just the child can be managed by the, and there are lot of investigation which can be needed and on a fast basis for the child.
Would you admit this child or would you
Yes, sir,
manage it
sure.
on OPD basis?
Sir, I'll admit the child. Sir,
Why
sure.
would you admit the child?
Because if it turns out to be obstructive jaundice because of biliary atresia, the need of early surgical correction is needed, sir. And the child is also less than, child is around 45 days, so early surgery will be very good for the child.
Okay, fine.
You have to counsel the parents, the child needs admission and further investigations and either surgical procedure or whatever the thing according to the investigations report. You just counsel the patient that the child needs admission and further procedure. Okay,
Yes, sir.
proceed.
So then how will you investigate after admitting? Is there anything else will you do after admitting this child? Apart from the counseling that you have done?
Sir, I like to go for my investigation part, sir. Growth
Sorry?
assessment.
See, you are not very clear, doc. So either speak slower and louder, okay, or come into the mic.
Yes, sir.
Yeah. So is there anything else that you would do after admitting? Apart from the investigations that you're planning to list?
Sir, I like to give that, I'll work on the diet of the child, sir.
Okay. So you look at the nutrition of this child.
Yes,
Correct.
sir.
Anything else? Would you like to give any supplements?
So yeah, I would like to give the pre-op supplements, sir, like vitamins and probable vitamin supplementation, sir.
Which ones?
Sir, fat soluble vitamins, sir, vitamin A, D, E, and K, sir.
Okay. So how will you give them?
So routinely we give them a solution of 1 ml per day, sir. 10,000 international unit of vitamin A, 1,000 international unit of vitamin D. Yes, sir. And 1 mg
And vitamin K, how do you give it?
Sir, we give by weight 0.55 mg per kg, sir. OD at least for 5 days.
How do you give it? You give it orally or subcutaneously
Sir,
or
IM, sir.
IM? Okay,
Yes.
fine. And then anything else would you like to do?
Sir, I can add MCT oil in the MCT oil for the child, sir.
Okay, fine. Go on with the investigations then.
So on investigation, the child by sir HB is around 9 gram per deciliter. The TLC is 14,000 and platelets were in the normal range. The electrolytes and urea creatinine levels are normal for the child. However, the direct bilirubin is raised for the child, and liver enzymes are 90, ALT and AST are within hundreds, and ALP is around 100, sir. GGT for the child is raised, which is around 700, sir. INR and albumin. INR is normal for the child. Albumin is 2.4 for the child, sir. RBS is normal, and rest IgM torch profile and TS level and urine for reducing substance are negative for the child.
Right. So what is your inference?
Sir, this shows this child has a part of anemia, and there is a obstructive pattern of jaundice for the child because there is a direct bilirubin is raised with GGT levels are raised, sir.
So when do you classify a child to have conjugated hyperbilirubinemia?
Sir, if the direct bilirubin levels are more than 1 mg per dl, sir, or more than 20% of the fraction of the total bilirubin levels, sir, we qualify the child. We suppose the child has a case of double hyperbilirubinemia.
Okay. And what is SGOT and SGPT?
Sir, they are the hepatocellular enzymes which were raised in hepatocellular injury, sir.
So which is more specific for the liver?
Sir, ALT is more specific for the liver.
And what is the full
SGPT.
form of SGPT? Or SGOT? Anyway, find that out.
Sir, transamineral.
Okay, no problems. So those are raised here, correct? I presume, because you've not written the normals. So that's less
Sir,
than
they are
40 is normal, correct?
Yeah, they are less than 3 times of the sir. They are
Correct.
within the normal range, sir.
Okay, okay. So amongst these liver functions, which are the synthetic functions of the liver?
Sir,
Which tests
coagulation
are
factors,
indicative of the synthetic functioning of the liver?
coagulation and the albumin levels, sir.
Correct. Okay. And the others, SGOT, SGPT are representative of what?
Hepatocellular injury, sir.
And the bilirubin is representative of
Excretion function of liver, sir.
excretory functions. Fantastic. Okay. And the torch is negative.
Yes, sir.
So what has been assessed in the torch?
Sir,
What is
we
the
have
full form
access-
of torch?
Sir, toxoplasma. It is toxoplasmosis. O is for other virus like syphilis. R is for rubella. C is for cytomegalovirus, and H for herpes simplex, sir.
Okay. So amongst these, which of the ones that are associated mostly in the current literature with biliary atresia, do you know that?
Cytomegalovirus, sir, has a linked with biliary atresia.
Okay.
Rheovirus and rhinovirus are also associated with biliary atresia, sir.
Correct, correct. And you said thyroid function tests are normal. TSH is within normal limits.
Yes, sir.
Why did you check the thyroid function test? What is
The
its
thyroid,
association?
the thyroid congenital hypothyroidism is itself a cause of cholestatic jaundice, sir.
Okay, fine.
करेंगे
fine.
करेंगे
And urine for reducing substances will rule out what?
Sir, it will rule out the disorders like galactosemia, sir.
Okay. Okay. Or other metabolic liver diseases.
Yes, sir.
Okay. Thank you. Dr. Shankar Bharti,
Yeah.
would you like to ask?
Yeah. What is the significance of the torch in regards to biliary atresia, doctor? Why should we do all these viral markers, IgM?
Sir, IgM, we do itself because the congenital torch infections can lead in the maternal torch infections can lead to neonatal hepatitis, sir.
Okay.
Torch induced, and for that we have to check for the IgM levels of the IgM serology for that, sir.
Okay.
And
Is there any
also,
role? Yeah, tell me.
yes,
Yeah.
sir. It's a biliary atresia. If it is associated with CMV, sir, it has a very the prognosis is also bad, sir.
Yeah, that is the point.
Correct.
So whenever there is a associated viral infection with BA, the prognosis is bad. That has to be explained to the parents when you are treating. Okay,
Correct.
very good, doctor. You are doing well. Yeah, proceed.
Sir, I am going for radiological imaging, sir.
Yes.
That the passing ultrasound of the child has been done, in which the liver is around 6.5 centimeter. There is a slight irregular contour of the liver. The IHBR is not visualized. The gallbladder appears hypoplastic. CBD is not visualized anterior to portal vein. There is no portal vein dilation, and the spleen and pancreas appears to be normal.
Did they mention anything about free fluid in the abdomen as it is in ultrasound?
Sir, they didn't mention, but child is clinically there is no fluid, and they did also mention, sir.
Okay, no fluid in the abdomen. Okay.
Yes, sir.
Okay, what is the inference of this ultrasound regarding this case?
Sir, after seeing this ultrasound, there is a mild hepatomegaly with there is no dilation of, there is no IHB, there is no intrahepatic biliary radical which are visualized, and there is a hypoplastic gallbladder. It means there is a suggestive, there is a extrahepatic biliary tree which appears to be atretic.
Okay. So you have mentioned it's a fasting ultrasound. That is good. Did you do anything else to do an ultrasound for this particular type of things?
So we
Did
can
you give
also go
any?
for,
Yeah.
yes, we can also go for postprandial ultrasound, sir.
What? Post?
Postprandial ultrasound, 30 minutes after
Post.
having child.
Yeah. Postprandial. Okay.
Yes, sir.
Any
Yes, sir.
other medication you give, then you go for ultrasound?
We can give secret,
Role of phenobarbital?
sir, usually we phenobarbital, sir, because it is an enzyme inducer, sir, phenobarbital can be given before the child having an ultrasound, sir.
On the doctor, can I ask Dr. Shankar Bharti?
Yes, sir. Please, sir.
Yes. So on the ultrasound, if you have a good sonologist, is there anything else you would look for?
Yes, sir, we will look for like we look for the free fluid in the abdomen, sir. We look
Correct.
for the if there is any associated is like in this case, the spleen is normal, sir. We will look for triangular cord signs, sir, if we are suspecting a case of biliary atresia, sir. Yes, sir.
And any other signs that you know of in biliary atresia that can be picked up on ultrasound?
That there is a ghost gallbladder sign, sir.
Sorry, yes, ghost gallbladder. What is that sign?
Sir, it is an irregular lining of the gallbladder with irregular contour, sir.
Along with, so it's a gallbladder ghost triad, it is called. There are three things to it.
Along with the, sir, total.
It is an abnormal gallbladder size, along with a thickening of the wall of the gallbladder, okay,
Yes,
and mucosal irregularity. So this is called as a ghost gallbladder triad.
yes, sir.
So that's something that you can look for if you have a good sonologist. And something else on this sonography pertaining to the vasculature.
So you can look for the right hepatic artery.
What will be special with the right hepatic artery?
So you can look for
No. See, what you can find is a large common hepatic artery. Nothing special with the right
yes.
hepatic artery. Generally, in patients with biliary atresia, they have a large hepatic artery. And if that sonologist is a very good one, there are some centers which are dedicated to biliary atresia who do something called as a hepatic arterial index. Okay, so
Yes,
what
sir.
is the flow from the artery into the liver?
Yes.
Plus, as sir said, ascites, spleen, plus preduodenal portal vein also
Portal
can be
vein.
picked up on
Yeah.
sonography.
Can you define what is triangular cord sign, doctor?
The triangular cord sign is the fibrous echogenicity which is anterior to the right portal vein, sir. If it is more than 4 mm of the thickness, it is suggestive of a biliary atresia, sir.
Okay, okay, good, very good.
Good, good. So go ahead with the next. So
Sir,
test.
sir, I would like to interrupt. We are done with 35 minutes. We have more right now, 15 to 20 minutes to cover up. So
Okay,
we need to fasten a little bit.
Yeah, yeah, yes, yes.
Sir, we have gone for another imaging, sir. It is a HIDA scan for the child, which shows the liver is enlarged and initial parenchymal tick by the hepatocytes with relatively preserved background, increased background activity. However, there is a no dye which shows the enterobiliary flow even after the 24 hours. And your gallbladder is also not visualized during this study, sir.
Okay, do you routinely do HIDA scan in your center, doctor, or is this done somewhere else and the child has come?
Sir, if the child is around 32, if the child is less than 1.5 months, we can go for HIDA scan. But if the child is more than 3 months or 4 months, sir, we don't go for HIDA scan. We'll straight away go for
But most of the centers, I think they have given up the HIDA scan. Okay.
yes.
And do you
If
prime
there is,
children prior to HIDA scan?
Yes, sir. We always prime children for HIDA scan, sir, before HIDA scan.
With what and for how many days?
Sir, we'll go for 5-day priming, sir. We with the enzyme inducer like phenobarbital and the cholinergic agents, sir, UTC, sir. And sometimes we
Okay.
also give a steroid, sir, to increase the
That is
flow.
what sir is saying. In today's world, we don't want to lose these 5 days priming.
Yes.
And now coming back to when I asked you, what will you do when you admit the child? Is you immediately start them on phenobarbital, because if you are going to do a HIDA scan, the child is primed for 5 days and you don't waste time. So in addition to the supplements and vitamin K that you're giving, okay, we tend, maybe one couldn't, okay, we tend to start them on phenobarbital and UDCA as well. Okay, this was the point that I was referring earlier.
Thank you, sir. Thanks. Sorry, sir.
Go on, go on.
Sir, so finally, sir, I complete my history examination with the available investigation. Sir, the 45-year-old baby girl with persistent jaundice since last 30 days, ecolic stool with dark urine, afebrile, examination shows icterus and hepatomegaly with no sepsis, stigmata, clinically stable, with lab investigation suggestive of obstructive jaundice, with USG suggestive of hypoplastic gallbladder with mild hepatomegaly, and HIDA scan suggesting no intrahepatic, no biliary flow, sir. It is likely to be a case of biliary atresia, sir.
Someone's asking a question. Do you do liver biopsies in your center? And what are your thoughts on a liver biopsy in such a patient?
Sir, we can go for liver biopsy in this patient, sir, because the child is still less than. If the report can be available within 50 days of the life, sir, then we can go for liver biopsy, sir.
what is
But
the prerequisite for liver biopsy? Sorry, sir, what is the prerequisite? That is, what do we expect? Because if you have, what is the prerequisite?
Sir, the child should have normal coagulation profile, sir.
No, I'm not talking about this disease or child, some other. You need a very good pathologist
Yes,
to
sir.
interpret whether it is a biliary atresia or a neonatal colitis. That is the very, very, very important thing in doing liver biopsy in biliary atresia. That too only should do in early cases, not for delayed cases. Okay.
Yes, sir.
Yes.
and what are the features in picking up a biliary atresia on a liver biopsy?
So there is a bile ductular proliferation, sir, very potent. There is a total, is a bile ductular proliferation, very potently. There is a total ductular proliferation. There is a bile flux, giant cell inflammation, infiltration, sir, and there is a bridging fibrosis, sir.
Okay, correct. And what would you like to differentiate it from?
Sir, I elected to differentiate it from neonatal hepatitis, sir, TP and associated cholestasis, sir.
So what is the picture in neonatal hepatitis, which is different than biliary atresia
So
histopathologically?
Yes, sir. Sir, there is a hepatocellular disarray and there is no ductal proliferation in case of neonatal hepatitis.
And no fibrosis.
No fibrosis. Yes, sir.
Okay, fine. So you've done all this. So what's your next step?
Sir, after this, in our center, sir, we go for liver biopsy, sir, because the child is still 45 days, but we can also go for surgical exploration in this case.
Now, how do you do liver biopsy in your center? Do you image guided or a mini open and do a liver biopsy?
So we do CT guided liver biopsy, sir, under G.
Okay, image guided liver biopsy. Okay, okay.
Yes, sir.
Okay, good, good.
And say the liver biopsy is suggestive of biliary atresia, then how would you proceed? And if the liver biopsy is not suggestive of biliary atresia, how would you proceed?
Sir, if the liver biopsy is suggestive for biliary atresia, then I'll counsel the parents and I'll take up the child for sir, Kasai Poto enteroscopy, sir, with intra-op cholangiography.
And if it is not suggestive of biliary atresia, how would you proceed? Because you've got a HIDA that is non-excreting.
Yes, sir.
So how will you proceed?
Sir, what the liver biopsy will show, then I will go for according to that, sir.
Sorry?
What the liver biopsy will show, then I will go for according to that, sir.
Okay, so the liver biopsy, if it is showing neonatal hepatitis and the HIDA is non-excreting, then what would be your step?
Sir, HIDA just can rule out there is a no biliary atresia. It cannot rule in this biliary atresia.
No, you have shown me your HIDA. See, I'm talking for the case that you are discussing.
Yes,
There
sir.
the HIDA is non-excreting.
Yes, sir.
So you done a liver biopsy because you do it at your center. The liver biopsy is suggestive of neonatal hepatitis. See, if it's biliary atresia, you are very clear. You will go
Yes,
ahead
sir.
with a Kasai Poto enterostomy. I am giving you a situation where it is not. So it's contradicting. So how will you proceed is my question.
Sir, I will go for intraoperative cholangiogram, sir.
Why would you do that?
Because it's the gold standard, sir.
Correct. So I would agree with you that I would still proceed with an intraoperative cholangiogram. Suppose the torch titer were to show CMV positivity in terms of IgM positivity with a high viral load. How would your approach be different? And the rest of the situation is the same for your baby. Have you understood my question?
Yes, sir, I understood, sir.
Okay. So anyway, I think we are short on time, so I will tell you. One is you will counsel as, sorry?
Yes, sir. Yes, sir.
No, keep talking. I'm very happy to hear. And I'm happy to hear from other people also, whatever they say. How will you proceed? Because I'll counsel for a poorer outcome, as Dr. Shankar Bharati had told you. Okay, one, because the CMV is IgM positive, then start treating for CMV positivity.
Yes,
Okay,
sir.
because it is IgM positive. So you give ganciclovir. And
Yes,
there
sir.
can be a concomitant CMV positivity and biliary atresia. There are reports worldwide. So you will still proceed ahead with a IOC. Either you can do it laparoscopically or you can do it with a small incision, because there can be a concomitant biliary atresia with CMV positivity also.
Yes, sir.
Okay, fine.
Yes, sir.
Okay. What is the outcome for Kasai in your center, doctor? Or generally, what is the prognosis following a Portra enterostomy in early biliary atresia cases?
Sir, in early biliary atresia cases, if it is done, then 1/3 of the child are cured, sir. That they pass stool, colic stool within 14 days of the enterostomy, sir, proto-enterostomy, sir. Rest 1/3 will pass stool, initially colic stool, but later on they will turn to acolic stool, and 1/3 of the child never pass colic stool still after proto-enterostomy. In our center, sir, the challenge is the child presentation is usually very late. If the child came around 4 months, 5 months, 6 months, or around some child around 7 months of age. If the child will present before, like this child presents to us within 3 months of the age, the still the cure rate is around 25 to 40%.
Okay. What is your protocol for post-operative management in Kasai?
So in post-operative management, we put child for milk per oral for 2-3 days, sir, with NG aspirations. We'll give antibiotics, sir, for initially for 4 to 5 days. IV antibiotics. We start with once the child is turns oral, we start with say UDCA and phenobarbital, sir, syrups, and vitamin A, D, E, K supplementation, sir. And
Okay.
along with, yes, sir.
Okay. Do you give steroids, or just I want to know whether you are in a center you are practicing that? Do you give
So we don't give steroids.
steroids? Okay. Okay.
What are the complications you can anticipate post Kasai proto-enterostomy?
So there are surgical complication and the late outcomes, sir. Surgical complication like related to surgery, sir, there can be anastomotic leaks, sir. And for late outcomes like the cholangitis, sir, which is one of the main complications, sir. Yes, sir.
And what about portal hypertension?
Yes, sir. There can be post-Kasai gastropathies and portal hypertension, sir.
Okay. And what about ascites?
Sir, later on in the portal hypertension, the child has, sir, ascites, and child also has ascites, sir.
Okay. Okay. And what about nutritional complications?
The nutritional complication, the child, we are supplement, the child is generally we are giving supplementation, sir, for the child.
Okay.
But yes, sir.
Okay. And
We
what do
also
you
feed
feed them post surgically? You had said MCTs you start
Yes, sir.
right from
We
it.
give routinely we give medium chain triglycerides, sir, around 1 to 2 ml per kg per day. Yes,
Right.
sir.
And what
Yes.
is the rationale in giving medium chain triglycerides to these
Sir,
children?
they don't require fatty fat soluble vitamins, sir. And they are also very high energy, sir.
Okay. Okay. Fantastic.
Yes.
Sir, do you want to add anything? Dr. Shankar Bharti? Anyway, I don't know why is he not talking. So are we done for our time, Dr. Mehta?
Yes, sir, we are almost done. We can ask one last question. There are questions in the chat box. People are asking what is the role of transplant? So we can have him answer that, sir.
Yeah. So what is the role of liver transplantation, Doc?
Sir, the role of liver, generally only 1/3 of the child are cured by the Kasai enterostomy. Later on, around 60 to 70% of the child require liver transplantation. If there is even after cured patients, there is a intractable there is a recurrent cholangitis or recurrent portal hypertension or growth restriction, then we have to offer liver transplantation.
So just say that what are the indications for liver transplantation post Kasai enterostomy?
The recurrent cholangitis,
Yes.
liver, this growth restrictions,
Sorry.
growth restrictions, portal hypertension.
What is the other one you were saying? One is portal hypertension. The second one I can't hear.
If the liver failure is causing growth
Liver
restriction,
failure. Okay, liver failure. Fine, fair enough. What else? Persistent cholangitis, you said.
yes, sir. I said
What else?
persistent cholangitis, liver failure, acute liver failure, sir. Oh, liver failure, sir.
Uh-huh.
Growth restriction, sir.
Okay, okay. Fine. So
Yes, sir.
what are the results, combined results with liver transplantation and with Kasai portoenterostomy?
So liver transplantation in a case of early liver transplantation uh, has a good outcome, sir. In case of
Any percentages with survivals, 10-year survivals?
sir, I have no percent.
Okay, okay, okay. And the, you know, uh, post liver transplantation, what are the problems one can envisage with such small babies having transplanted livers? Any idea?
So there is a long-term immunosuppressants are required. The post transplantation
Yes. So what are the
therapies are required.
complications of transplantation in children this small? What's something plaguing these children beyond? Yes, immunosuppression, but what problem these immunosuppressions cause to the transplanted child? Any idea? What is PTLD?
Post liver transplantation.
PTLD, transplant lymphoproliferative disorders.
Yes,
Apart from the structural complications. So they can get rejections, acute rejections, chronic rejections. They can get narrowings of the arterial anastomosis or the ductular anastomosis. They can get strictures, they can get leakages, and they can get malignancies. And what's plaguing now, because now post-transplant, you are having a lot of numbers that are surviving, okay, these children, but they are coming up with PTLDs. So that's something that is plaguing them. Okay, so it's very easy to help these children with a transplant, but then when you fight nature, the nature gives it back to you in various forms. So anyway, I think we've had a brilliant session, and this being a first one, we have grilled you too much because we don't have a yardstick. But you are very good. You are very good. Because I did it with the idea of me learning something from you all. Okay, so I think you're
Thank you
brilliant.
so much.
Fantastic. Yeah.
It was a
Thank you so
wonderful
much.
session, sir. Sir, you would like to give a feedback to the students, sir?
Yeah, sure. We'll fill the Google form and send it to you.
Okay,
So
sir.
you want the feedback right now, live, or on a feedback on the some sheet that you are going to send?
Yeah, we'll give.
Sir, we'll
Yeah.
be sending you the mark sheet, so you can give the marks on that. And sir, like for further presentation, any sort of suggestion you have, you can just give it to us, so that we'll be improving in our next session, sir.
Yes.
Okay.
I've sent you the Google form, sir. So it's on your WhatsApp. You can just fill that in, sir.
Yeah,
Okay.
sure.
I hope it is not an exhaustive form, Evangeline.
No, sir. No, sir. Just we have.
Because I think he was very brilliant. Yeah, you've
Yes, sir.
done
Yes,
very
sir.
good. Actually,
Yes,
I
sir.
have learned from your negative history. There's so much. I didn't know eye spots and all that. So that's brilliant. Okay. So take care. Have a good night and wish you all the best for the exams. All of you, I presume, are
Thank you,
exam
sir.
goers.
Thank you so much.
Okay.
All the best. All the best.
Thank you
Yeah,
so much
you
for
all will do
taking
well.
out your time for
Thank
us, sir.
No
Thank you.
worries. No worries. Always a pleasure. Okay. Take care.
Thank you, sir.
Bye, Dr. Shankar Bharti.
Thank you, sir.
Nice interacting with you.
Bye, sir. Thank you, sir. Thank you very much.
Take
Thank you,
care.
sir.
Take
Thank
care.
you so much.